Mineral issues. You heard just a superb presentation yesterday by Andrew Mente on the role of sodium, and he didn't get much into potassium, but implicated that that's also extremely important. When you're fasting, there are two things that are going on. One of them is there's something called the natriuresis of fasting. And natrium is the Latin term for sodium, and it's accelerated sodium excretion with fasting. And this is a very robust observation, and it's been very well characterized in humans and in dogs. Dogs make superb analogs for humans in that regard. And this, when you're going into nutritional ketosis, the body doesn't conserve sodium; it accelerates sodium excretion. But if you're totally fasting and you're not consuming sodium, you're going to be depleting sodium, which is mostly in the circulation and extracellular fluid. When that contracts, renin is released from the adrenals, aldosterone goes up. Aldosterone is a damaging stress hormone, and that subsequently leads to cortisol increases. And the other thing that aldosterone does is in order to try to cling to sodium, it makes the body waste potassium. So you get this double whammy of shrinking sodium volume and losses of potassium. So even if it's a few days, on those few days when you're fasting, those are days when you're not getting in sodium and potassium, and you're basically building a deficit that need to be repleted after the fast, whether it's a 2-day fast or a 1-week fast. And then also magnesium is lost as you lose lean tissue, and if you're going to gain back that lean tissue, it's going to require greater magnesium intake beyond the normal required level to achieve that. Whether it's intermittent fasting, where you have a few days of deficit per week, those days of deficit have to be made up with your diet in the intervening days, which means that the nutrient density of minerals in the diet needs to be not just adequate, but superior. And we very seldom take that into account. Interestingly, there was just this paper published, I think, last week, looking at intermittent fasting and effect on risk of hypoglycemia in a randomized controlled trial. And these were people who were fasting either for 2 days intermittently or 2 days consecutively during the week. And you can go and look at the reference, but what they found was even though they withdrew or reduced medication on the fasting days, so they told people if you're going to fast, reduce your medications, they still doubled their risk of symptomatic hypoglycemia. So when you're on a medication to control blood glucose and you markedly cut or dramatically change your carbohydrate intake from day to day, you're going to get into a roller coaster ride. And that's a risk. I'm thrilled Dr. Bickman mentioned refeeding syndrome. That this is something that I was not taught in medical school, but I learned it in clinical practice because much of my practice when I was in academic medicine, teaching and practicing nutrition was I was doing in-hospital nutrition support with intravenous feeding, TPN. And when you take a patient who's been fasting, they get transferred from a hospital where they didn't do TPN, this was back in the old days, and they came to our center where we did do TPN, and the surgeons would tell the pharmacist, start them on TPN, and the nurse and the pharmacist would put them on TPN with high glucose, and the normal amount of phosphorus, magnesium, and potassium. We would oftentimes see profound reductions in the blood levels of potassium, magnesium, and phosphorus, which can impair respiratory and cardiac function. They say, hey, the guy looked pretty good. We put him on TPN, and now he's on the ventilator and comatose. What happened? And this guy's phosphorus level's 1.0, and it should be above 2.8. And that's refeeding syndrome. How was this discovered? This was discovered when people were rescued from lifeboats or rescued from situations of prolonged starvation, and to be nice to them, they gave them copious amounts of food. When you're fasted and then you suddenly feed, particularly with carbohydrates, and you put a lot of glycogen into a glycogen-depleted muscle, potassium, magnesium, and phosphorus have to shift out of the plasma into the muscle, and you create at least oftentimes profound transient blood levels, lowered blood levels of those key minerals, and you can put a person into coma, heart failure, and even kill them by doing this. Something that should not be ignored. And after a prolonged fast, someone really needs careful dietary and medical supervision through the feeding period. And just telling the person, as is quoted in one popular book, just don't binge, I don't think is adequate respect for this dangerous situation. So the summary is, early and ongoing lean tissue losses are not minor, that there can be prolonged reductions in resting metabolic rate, and the longer one fasts, the greater the reduction goes down, and we don't know how fast or what the individual variations for people in recovery of this important metabolic parameter. That one of the behavioral problems with intermittent fasting is that if you do it one day a week and you get some benefit, and then that tapers off and you want to get more benefit, then you do it 2 days, and then you say, well, I'll try a 7-day fast, and you end up with a law of diminishing returns. And people want to keep this line going down straight by doing more and more extreme efforts. And that's the slippery slope. And we should stay away from that.